Hi everybody, welcome back to the Code Blue Classroom. My name is Ashley, ear nurse and nurse educator, and today we are going to start the next segment of our drowning topic. So we're going to go over the anatomy of drowning today. Drowning causes respiratory impairment as a result of immersion or submersion in a liquid. This can happen super quickly, as fast as 20 to 60 seconds. Now, let's dive in. This voluntary breath holding can last up to about a minute. So despite all of those efforts we had as children to hold our breath for as long as possible underwater, there is no real prolongation past that 1 minute marker. So part 2 is going to be involuntary. Part 1 was our voluntary breath holding mechanism that lasts up to a minute. Part 2 is going to be involuntary laryngospasm. So this is where water is going to touch the back of the airway, and there's going to be a spasm of those vocal cords, which results in a closing off of the airway. This is a very also brief moment, because the moment there's a hypoxic level reached for the brain, that involuntary spasm and process completely goes away, which then leads us into step 3. So part 3 is going to be aspiration. As we head to the end of that laryngospasm that's occurring, where it slows down, we have an increased drive that for inspiration, and that is just truly irresistible. It's the body's protective mechanism to try and keep itself alive by breathing. Unfortunately, when we inhale underwater, water then goes down the airway and we aspirate that into our lungs. So the victim is going to breathe in that water, and that's going to cause an involuntary coughing and gagging reflex, which causes an intake of more water and then spurs us into the fourth segment, which is hypoxia. So once we reach point number 4, hypoxia, our brain requires oxygen in order to function, and in turn, when our brain doesn't get the amount of oxygen that's required, the victim will have a loss of consciousness subsequent to the hypoxia. After the loss of consciousness occurs, the patient will become apneic, and this is because those driving processes in our brain are no longer telling the rest of our body to take breaths. This apnea will then subsequently, within seconds to minutes, lead into cardiovascular failure. Once oxygen is shut off to the brain, those regulatory signals that the brain sends to the body completely cease. And this is then where we will head down the path of cardiovascular collapse. For drowning victims, once we reach the point where we're heading into cardiovascular collapse, there's a progression through 4 dysrhythmias that occurs. The initial dysrhythmia is going to be tachycardia. Our heart rate's going to go super high, and then there's going to be a subsequent drop in the heart rate, which means bradycardia. Our heart rate's going to go very low. And then the next step after that is going to be PEA, pulseless electrical activity. So it'll look like, if we put this patient on a monitor, that they will have a heartbeat electrically, but when we feel for a pulse, there won't be one there. And then the last step would be asystole. So we kind of bypass those ventricular dysrhythmias that we see in other causes of cardiac arrest. So now that we talked about those 4 segments of the continuum of drowning, it is really important to note that kind of stopping at any point in the continuum can help improve patient outcomes. So for example, if we get to the point where we're breath holding and we start to head into laryngospasm, if the victim is pulled out of the water by the time they reach laryngospasm, hopefully the effects of drowning won't be as profound as someone who reaches the step 4, the level of hypoxia. So let's get really technical now, because this is kind of some of the geeky stuff that I really like. So there is some correlation between the volume of water that is aspirated and the severity of injury. Now, there are some studies out there that indicate, when they look at the postmortem for a victim who has died of drowning, there's actually a really low volume of water that's in the lungs. And some of this is because what's happening anatomically. So once the water gets inhaled into the lungs, it gets mixed with the surfactant that's in the alveoli, and it creates a process of saponification. Surfactant is what helps keep surface tension, right, on our lungs, and helps prevent collapse or atelectasis, We hear so much about this on like the baby end of the spectrum when we have premature infants in nursing school. That's the big topic. But really there's so much to do with surfactant in our drowning patients. So once the victim inhales the water and it mixes with the surfactant, it creates this saponification, like I said, and it bubbles. And you'll get like a foaming and a frothing in the patient's mouth. So when we're bagging these patients, we actually don't want to suction that out because it's super necessary. We need that surfactant to help prevent further atelectasis and create great surface tension in our alveoli. So current recommendations are to actually just bag through those secretions and that foaming, and don't suction it out. You can work on an advanced airway at that point, but it will be more difficult just to see, which we'll go into that when I do a video on treatment. This surfactant then causes an alveolar membrane disruption, and it causes increased permeability, allowing fluid, plasma, and electrolytes to cross that membrane more easily, and causes a pulmonary edema of sorts that's non-cardiac in nature. So the non-cardiac pulmonary edema plus the loss of surfactant plus the increased permeability all then leads to a VQ mismatch, so a ventilation perfusion mismatch. We have this hypoxia that's not improving, and we're then not going to be able to perfuse, so the scales kind of tip here, and this results in profound hypoxemia. There's a really cool kind of flow sheet that breaks this all down, so I'm going to show you right now and we can go over it. So part 1 is the water aspiration, which then results in our surfactant washout, plus the alveolar capillary membrane injury. Remember, that causes the collapse of the alveoli, then this all results then in non-cardiac pulmonary edema. That, coupled with the atelectasis plus the VQ ventilation perfusion mismatch, results in progressive worsening hypoxemia. That hypoxemia then results in metabolic acidosis, which then causes cardiac rhythm deterioration, which then causes hypoxic cardiac arrest. And then in turn, that creates a hypoxic brain injury. So that does it for Anatomy of Drowning video. I really appreciate you guys watching. If you guys have any questions, please leave in the comments down below. I truly believe that knowledge is your best code card, so please stock it well. Stay tuned next time, guys, when we talk about the treatment and the diagnosis tools for drowning victims. Bye!